Byron is a HIV surveillance officer at Communicable Disease Control Directorate, and many of you will be familiar with Byron's work and presentation. And he's also presenting on behalf of Kelly Mitchell today. So thank you, Byron.
Thank you. My colleague Kelly Mitchell sends her apologies. She works part-time and isn't here today. So she put together the slides on the STI and BBV trends, which I'll present on her behalf, and then conclude with the HIV epidemiological trends. That's all right. I had that upside down, okay. Okay, so basically what we've tried to do is provide a bit of an overview, a broad overview of the STI and BBV epi trends for WA, just so you've all got a bit of background information for the next 2 days of discussion. So we'll start by looking at infections where we received the largest number of notifications. And what we've done is provided data for 2015 and then compared it to the previous year as well as the previous 5-year average so that we can see trends over time. And you can see here generally for these infections the trends have been relatively comparable over time. I guess the largest change would be the increase in gonorrhea notifications in 2015, which were 20% higher compared to the previous 5-year average. Now for the diseases where we receive a lower number of notifications, you can see here that the largest increases were seen in infectious syphilis notifications as well as newly acquired hepatitis C notifications in 2015. So in some of the later slides, I'll be going through some of the trends behind these increases. In comparison, newly acquired hepatitis B notifications have remained relatively stable over time. So now we'll discuss the STI testing data, and just a warning, the next few slides, there are a lot of data to digest, so if you can stick with me for the next couple of slides, we're doing well. So we'll start by looking at the chlamydia testing rate on the left there. And if you look at the dark blue line, the dark blue line, you can see that over time the testing rate for chlamydia has increased over time. Over the same period, we have seen a decrease in the notification rate for chlamydia, as symbolised by the grey line. And corresponding with that decrease, we've also seen a decrease in test positivity. So in other words, we're seeing a decrease in the number of chlamydia tests that are coming back positive, which is an encouraging result, as it suggests we may be seeing a decrease in chlamydia transmission in Western Australia, particularly as we've also seen an increase in testing rates over time. If we look at the gonorrhea testing rate, over the same time we've also seen an increase since 2010, but over that time we've also seen an increase in both the notification rate and the corresponding positivity rate. So the main summary point from that graph is that we're seeing an increase in the gonorrhea notification rate, which may be a combination of increased testing, but also a possible increase in gonorrhea transmission as well. Just finally, for our STI testing, the syphilis testing rate has fluctuated over time, but in the long term, the numbers have remained relatively stable for most years at around 35 tests per 1,000 population. Sorry about the graphs here, they're a bit hard to interpret because they're a bit low, but what these should show is that we've seen an increase in both the notification rate for syphilis as well as the positivity rate for syphilis. So I guess the main summary point here is that even though the syphilis testing rate has remained relatively stable, we have seen an increase in the syphilis notification rate, and that suggests, again, a possible increase in syphilis transmission. Now to our blood-borne virus testing data. And we'll start by looking at hepatitis B. These results have fluctuated over time, but all three trends, so the testing rate, the notification rate and positivity rate, have all shown downward trends in the 2010 to 2015 period. So the main take-home message in regards to the hepatitis B trends is that overall we have seen a decrease in the hepatitis B notification rate, but that's likely a combination of both a decrease in testing and again a possible decrease in hepatitis B transmission. And finally, if we look at testing rates for hepatitis C, This too, the testing rate, this has fluctuated as well, as symbolised by this blue line again. But overall, we have seen an overall trend downwards in the last 6 years. Over that time, though, the hepatitis C notification rate has remained relatively stable over that time, despite a spike in 2013. In that same time, though, we have seen an increase in the positivity rate for hepatitis C. So even though the notification rate for hepatitis C has remained stable, we've seen a decrease in testing, which again has led to an increase in positivity, which suggests there may be disease transmission increasing. So as I said before, we have seen a recent increase in infectious syphilis notifications in the state. So the next few slides will try and break that data down in a bit more detail. So you can see here, the syphilis notifications have increased in WA across the different exposure categories. So we've seen an increase among men who have sex with men, as well as heterosexually acquired infectious syphilis in both males and females. So we'll start by looking at the syphilis trends for men who have sex with men. And we'll look at, the data here shows us the infectious syphilis notifications for men in the metropolitan area by HIV status. Most of the increase we've seen in syphilis in MSM have been in the metropolitan area. And we've decided to represent the data by HIV status or pre-existing HIV diagnosis, because back in 2006 we did see an increase or an outbreak of syphilis among HIV positive men, and this was in a cluster of men who were serosorting, so basically they were having unprotected intercourse with other HIV positive men. It's unclear whether we're seeing the same trends now, but certainly some of these trends here are similar to what we saw at the start of that outbreak back in 2006. So you can see here the majority of syphilis notifications were in men who had not previously been HIV or diagnosed with HIV, but we did see an increase in the proportion of syphilis cases who had a pre-existing HIV diagnosis. The next slide shows us the rate of infectious syphilis notifications by sex and region. So on the left here we've got the rates for females by region, and on the right hand side you can see the rates for males. And you can see for both we saw notable increases in the notification rate for syphilis in the Kimberley region and to a lesser extent in the Goldfields, and that was seen in both females as well as heterosexual males. Now this was related to an outbreak in the Kimberley region and it was mostly seen in Aboriginal people. The outbreak started in Central Australia and in remote communities in the Northern Territory. Consequently, though, there were no associated cases of congenital syphilis as a result of this outbreak, and we haven't seen any concurrent increase in other STIs or BBVs related to this increase either. There is a session tomorrow on the multi-jurisdictional approach to this outbreak where you'll obviously hear about these trends in more detail. Finally, we'll look at the recent increases in newly acquired hepatitis C notifications. So here we've presented the rate of newly acquired hepatitis C by Aboriginal status. So you can see here the largest increases in newly acquired hepatitis C were seen in Aboriginal people, where the rate increased 42% compared to the rate in 2014. The vast majority of the notifications in newly acquired hepatitis C among Aboriginal people last year were from the prisons. In contrast, the same figure for non-Aboriginal people was less than half. So if you look at trends for newly acquired hepatitis C notifications among Aboriginal people in prison, and first of all, if we look at reasons for testing, we can see here that the most commonly reported reasons for testing were testing due to a history of risk factors, as well as testing as part of a prison health screen. And notifications for both these testing categories have increased over time and continue to make up the majority of new cases or new Hep C diagnoses in Aboriginal people in prisons. If you look at the same data here, again, looking at newly acquired hepatitis C notifications among Aboriginal people in prison, and look at the reported risk factors. The most commonly reported risk factor has been injecting drug use, followed by a history of prior imprisonment. Both these notifications in both these risk factors have increased over time, both in terms of absolute number as well as a proportion of all Aboriginal newly acquired cases. So finally, we'll finish off by looking at some of the trends we've seen in HIV recently. So here we have the total number of HIV notifications in WA since 2010. Last year we had 129 new cases of HIV notified in WA. That was a 10-case decrease compared to the previous year. But overall, there has been an increase in notifications since 2010, increasing by 13% in the last 6 years. If you look at data among males and females, and we look at the crude notification rate for HIV for males and females, the male rate showed an overall increase of 19% since 2010. However, since 2012, the rate has remained relatively stable at around 8 cases per 100,000 males. In contrast, the female notification rate for HIV showed a notable decrease over time. We saw a 41% decrease between 2010 and 2015, decreasing to just under 2 cases per 100,000 females last year. If we look at the testing rates, now we'll start by looking at the male testing rates. And over time, we have seen an overall increase in the male testing rate for HIV. Over the same time, we've seen increases in both the notification rate for HIV in males, as well as the test positivity. The test positivity has also increased for males for HIV. So basically, this recent increase in HIV notifications we've seen in males is likely due to a combination of both increased testing, but also a possible increase in disease transmission of HIV among males in WA, particularly in the last 2 years, where the positivity rates for HIV testing in males notably increased. As for females, we did see quite the opposite trend. Testing rates have declined overall since 2010. Over that time, we've seen a decrease in the notification rate for females. As well, the positivity rate for HIV in females has decreased. So this recent decrease in HIV notification rates in females is likely due to a combination of decreased testing, but also a possible decrease in HIV acquisition or incidence in females in WA. So if you look at HIV data by exposure category, HIV diagnoses among men who have sex with men continue to be the most commonly reported risk factor, and that's notably increased since 2010, from 40 cases in 2010 to 70 cases last year. It did appear to stabilise a little bit last year with a 7-case decrease compared to 2014. In contrast though, notifications for heterosexually acquired HIV among males has fluctuated, but overall this has remained relatively stable in the long term at around 30 cases each year. And as for the female heterosexual cases, we've seen a steady decline since 2010. So the next few slides will look at HIV notifications by place of birth and acquisition. So later on this morning, there'll be some discussion around HIV mobility populations, in mobile populations. So hopefully this will give a bit of a epi background to that discussion. So this slide, first of all, shows heterosexually acquired HIV among males in WA. So we'll start by looking at the dark red graphs, and you can see here, this symbolises the overseas born and acquired notifications. So you can see here, most of the heterosexual male notifications in WA were among overseas born men who had acquired HIV overseas. These were predominantly men from high prevalence regions, in particular sub-Saharan Africa. And in most cases, these were men who had acquired HIV in their region of birth prior to coming to Australia. The second commonly reported place of birth and acquisition were Australian men acquiring HIV overseas, and that's symbolised by the light, so I guess the pink line over the top there. These were men who had mostly acquired HIV in Southeast Asia, but the trends in this particular demographic were mixed. We did see men who had acquired it while they were on holiday in Asia, but within this cohort, there were also men who had split time between here and Southeast Asia, whether it was for work or sometimes they report having a current partner or a long-term spouse in Asia who they would split time between here and there. In the last 2 years though, overseas acquired notifications among heterosexual males have shown a small decrease and remained quite steady in the last 2 years. If you look at the same data before heterosexual females, these were mostly overseas-born females who acquired HIV overseas. For females, these were mainly females, again from sub-Saharan Africa, but that was followed by numbers of cases from Southeast Asia as well. Last year, we did see a lower number of cases compared to previous years, with only 12 notified cases of HIV among overseas-born women who had acquired HIV overseas. If we look at the same data, but among men who have sex with men, these were largely Australian acquired, but we do see a large proportion of men who were born overseas who had acquired HIV in Australia. Again, it was hard to actually identify a common trend in this cohort. These were most likely to be men who had been in Australia for a number of years, possibly citizens or permanent residents, many of whom had been here since childhood. And these were predominantly men who were born in the UK and to a lesser extent New Zealand and Asia. So I guess this trend here is probably more, or you could argue it's more a reflection of the demographic profile of WA and not, I guess, a reflection of any recent migration patterns in the state. Last year we also saw an increase in the notification rate for HIV among Aboriginal people. That increased last year to be greater than the rate for non-Aboriginal people. However, it must be said, the rate is sensitive to small changes in the number of cases, and this translated to 6 Aboriginal cases last year. Nevertheless, it was the highest number of annual cases we've seen in Aboriginal people in the last 6 years. So between 2011 and 2015, in total, we've seen 14 HIV notifications in Aboriginal people with an even split between males and females. Most of these notifications were heterosexually acquired. And unlike the other, I guess, non-Aboriginal HIV notifications, the majority of our Aboriginal HIV cohort were residents of the non-metropolitan area. In this time frame, we only had 1 Aboriginal HIV case that reported injecting drug use, but given the recent trends we've seen in hepatitis C in Aboriginal people with injecting drug use as a risk factor, it's a trend that we're keeping a close eye on.